we have this 63-year-old gentleman with cataract and moderate NPDR and CSM in both eyes. So he has been injected with Accentrix in the past. So the plan is to go for Phaco with Vivinex and Ozurdex implantation in the left eye. So you can see in the OCT also that there was some macular edema seen. The CMT is 370 and the chosen IOL power is 20.5 diopters.
Thank you very much. I'm absolutely floored by the huge galaxy of stars who have descended onto Kolkata this afternoon and the surgeries that have been going on.
To meet a superstar.
No, sir. And thanks everybody from the bottom of our heart. And I speak for all my whole team Trenetralaya and the extended team of BBEyeFoundation and Netralayam. Everybody, the whole thing is a family. And thank you for giving this opportunity to us. Bluedex. So I'm being assisted by Robi and Tista, and as I was telling Namrata that all our assistants are used to a large number of surgeons, and they are used to all the small nuances that every surgeon has of particular taste.
Partha, is it okay to ask you a question?
Oh, sir.
No, do you normally use a IOP of 20?
Sir, 20 to 26 so is the usual setting that we do.
I think that is the amazing capability of this machine that,
Yes, sir. Yes, sir. So again, I think, sir, I mean, when we started with the Centurion, we were not all very comfortable with it. And it was only with time that the comfort was there. And it's really amazing to see that the machine gives us such good outcomes. The first post-operative day, it is so comfortable and the patient is...
What are these two rings, sir?
Yeah. So this is the 5.5 and the
6
millimeter ring that is there. Yeah, the Callisto overlay is again a very good tool. The one thing that I purposefully do is the methyl cellulose is what I use, and whenever I feel that the methyl cellulose is not enough, definitely go ahead and push more. Like it is not the optimal and right now, so we'll do a little bit of more viscoelastic. This afternoon I was talking about the Lumera eye and the beautiful red reflex that it gives and the wonderful sense of the optics that it has. But what is also very important is it is quite uncomfortable at times because it shows so much and you feel that you have not done a good surgery. Whereas in the other microscopes the surgery would have been much easier and simpler. Again, these blades from Alcon are excellent blades, and next post-operative day itself you can see how good it is. And you can assess on the slit lamp the excellent position of the wound. And so viscoat is something that we routinely use for all our patients.
Your mask is... You have to be a little
And,
louder. That's what our Chitra is telling.
Chitra can't hear me.
No, she can't hear you.
Is she in Kolkata or Coimbatore? Okay, so that's the difficulty of a double mask, I think. Chop, please. আচ্ছা মাথাটা ধরে থাকো রবি মাথাটা ধরে থাকো So a straight chop is what I try and attempt even in the softer cataracts, and if it can be done, then nothing like it, and everything becomes much more easier.
Excellent chopping, Partha. Just a comment
Gel
about
down.
those bubbles over there.
Gel down.
I mean, sometimes when you have viscoat, it's a little thermogenic, and it might be a good idea to aspirate a little bit of it, right, along with the
Yes, sir.
cortex and the loose
আমার দিকে করো,
epinucleus.
মাথা আমার দিকে করো। The quadrants though, please. Grade 2, please. Grade 2 and quadrants. This is a small technique, I don't know, little homemade, I think. I try and wibble off this, and I feel that it is faster to remove the nuclei.
This is extra ozil you are showing, sir.
Automated ozil and mechanical ozil.
And you can see the IOP is 20.
Here I have to give credit to Sudipto of Alcon, who pushes me all the time. Arektu kom korun, arektu kom korun. He'll always say. But I think this concept of the lower IOP in which we are operating is something that is excellent. And next day the cornea itself is so good.
And that one engineers. You will see my latest video again on that and I'm sure we share with you. Okay. Okay, cataract, cataract, everything else. Okay. Because we are not upgrading. Even if it goes behind, we can do it. Yeah. Oh, cool. We often show it back because we have a friend. Delivered. Hello. Now we are your son. This view and take happens. हम लोग भी तुमको कितने बुलेट कराए तो पहले दिन.
Epinucleus.
You can see even at 20 IOP there was absolutely no fluctuation of that.
Yeah,
area.
that we could figure out, that even with the 20 IOP, the chamber was absolutely perfect.
Bishira. This is a 1.0 millimeter incision. I'm extending it a little more because at times what we do feel is that with an incision, the side ports tend to leak more than the main port.
Partha, we would like you to be a little louder.
Oh, I see, sir. What I said is we made a 1.0 millimeter incision, and just for the safety of the wound edges of the side port, we increased it.
So what size of port is this in this bimanual that you have? Tip.
My manual?
Possibly 0.5. Point? No.
No, sir.
We
It's,
used to
it's
point.
20 gauge. It's 20 gauge.
It's 20 gauge.
Okay. Yeah. With the usual IA, we were used to 0.3. Opening. It is depend on the size of the opening that is created.
So
0.3,
we are
0.5.
going to implant this Vivinex lens and do it through the irrigation. Otherwise, quite comfortable. The best part is the smoothness of the injector. It just goes so well. And they have these haptics which are nicely in place, and yeah.
Chances of jerk is so less with this injector system.
Ball dilator.
Yeah, jerk can sometimes be a real problem with some of the older injectors. You really have to think of the possible jerk in every case, and we proceed very cautiously in all those push models.
Yes.
So the viscoelastic doesn't really need to be removed because we did not implant it under the viscoelastic. So
Partha, how long have you been doing this hydro implantation? Would you like to say something about it? Because
yes,
after seeing guys like you only, I'm also trying it out now.
Yes, sir. So quite I think it would be at least 8 years, I think, sir. So all the implantations of a single piece lens is what we do with the...
So Partha, can you explain the advantages other than not having to remove the visco?
Yes, sir.
That you find with the hydro injection?
So time is one, of course.
Yes.
And that's not so important maybe, but for all toric implants, it gives a lot of
stability.
benefit. Yes, sir.
Possible movement is not.
We use intracameral Vigamox for all our cases, and that's something of a routine. Now, since this patient had a diabetic macular edema, so we are going to inject also Ozurdex here, and I'm trying to and I'm just with the finger pressure, I'm just trying to gauge what is the amount of intraocular pressure, which has to be just optimal and not more, not less.
What is this added advantage of keeping IOP at 20 instead of 30? Are you able to lower your parameters too because of that?
Well, actually, the IOP of 2025, it works. Paraken, please.
Let me put this in a different way. What difference has it made to your surgery or to your indications or any aspects of surgery since you have these machines which can give you a surgery at 20, 25, 30 millimeters of mercury? What difference has it made? Which patients particularly?
Sir, all our patients, the lower the IOP is, the better it is for the health of the cornea.
True.
And especially with patients with poor corneal decompensation or low corneal count.
True.
Glaucoma patients, high
glaucoma, especially those with advanced glaucomas. Yeah, that again.
High myopics.
High myopes, yes, where you otherwise give lot of pain with bag expansion. Then cases with zonular compromise, possibly.
Small pupil.
Yeah.
So as you could see, there was a little bit of
egress of
fluid. So I will put a little bit more fluid.
Okay, sure. That should be fine. Yes.
And then put in the Ozurdex.
I have the car. Yes.
Dada chokta chop them. Huh?
Yes, sir. We'll do that.
Awesome.
Yes. Thank you.
Sir, just a thought. Can visco wash can be done with after this injection?
Yeah, can be done.
Right.
Actually, Dr. Love, he has not injected
Yes.
visco.
Yeah, that slipped off my mind.
Yeah.
Dada, soja dekhun, soja dekhun.
So this is Ozurdex implant, right?
Yeah, Ozurdex implant, 0.7 milligrams of niche dike dekhun dada, opor dike dekhun, soja dekhun ebar. So you can see the shadow of the Ozurdex there, and I'll just check on the IOP, which is pretty much okay, I think. So, because if we do not use either anti-VEGF, and this patient had anti-VEGF for a very, very long time, I think 2 injections the patient had got already, and therefore the use of Ozurdex is what we had planned for, and anti-VEGF did not relieve very much of the macular edema. It would come and go, so this would at least give benefit for at least 3 months to 4 months of macular edema.
Yeah.
And the vision was less because of the significant amount of cataract than the macular edema. So if the cataract is removed, the macular edema also comes down. So the potency of vision is going to be restored to as much as possible.
Very good, Partha.
So thank you.
Have you
sir.
faced any case of
Pardon, sir, you know.
Have you faced any case of post-operative high IOP in any of these cases wherein you have injected Ozurdex?
Yeah, we have definitely had, and in about, I think our numbers are around 10 to 15% approximately with a raised IOP post-operatively approximately 2 to 3 months. So in the first 1 month to 2 months, we do not usually have it, but approximately 10 to 15% with a raised IOP. So we definitely call these patients every month to check the intraocular pressure.
Do you do a disc evaluation before giving Ozurdex?
Yes, sir.
Okay.
Disc evaluation 100%, and so even there are these recalcitrant edema in which the anti-VEGF is not working, and it's a compromised disc. So a correlation with our glaucoma consultant to see whether it can be controlled with topical medication, and then go ahead with Ozurdex if required.
Would you not prefer giving the Ozurdex injection first and later a cataract surgery, a little gap because of the macular edema which is there?
No, actually, it can be combined. Even studies have shown the combined effect has a reasonable outcome. So many people combine it and it works well.
Yeah, Chitra, your question was whether we could give the Ozurdex first and then do the cataract surgery later, is it not?
Yes.
Yeah. So that is absolutely a done thing, and we can do it. But again, that means 2 visits to the OR, and this works quite well otherwise. And patient is quite comfortable. Like, I did not put an injection or infiltrate with xylocaine, and just with the paracaine swab. Patient was not uncomfortable otherwise.
I just have a question about the technique of injecting, because many youngsters might be combining cataract surgery with intravitreal. So you made the patient look down, yes, the sclera was very well seen.
Yes,
but I actually asked the patient to look straight into the light, because whether it's Avastin or Ozurdex, I like to see the tip of my needle when I'm injecting.
Okay.
So in this case, that was a slightly blind.
I'll tell you, sir, the difference here with Ozurdex is because it has to go 1 millimeters in the sclera and then dip down. So that's the reason why I, specifically asked the patient to look up, so that I know that the scleral, the scleral tunnel that is created is at least 1 millimeters, and then, whereas in the anti-VEGF we go straight in most of the time.
But Partha, one tip for you.
Yes,
I
sir.
inject anything, whether Ozurdex or anti-VEGF in the lower nasal quadrant, because somehow one out of 100 may have hemorrhage, like a vitreous hemorrhage, trickle or black spots, they will say. This, if it is lower inferior nasal, it will sink down.
Now Partha is proceeding with his list of surgeries, so let's all watch.
Yeah, this is, I think, the last surgery that we'll be showing, though we have a set of other cases also, which were more or less backup cases. This is we'll be implanting an 80 Lisa lens in this case. I think the benefit of having so many, आलोक दिखे देखो ना एकटूखानी, आलोक दिखे देखो, बत्ती को देखिए, पेशेंट का नाम, शर्मा जी, हाँ, सो मत जाइए, सीधा देखिए, बत्ती को देखिए, सीधा देखिए, no, okay. So again, this is a softish cataract. In these cataracts, it's quite difficult to do a straight chop, but we'll try and try a straight chop for this also, because again, in the softish, no, Callisto, Vishan. Here with the 80 Lisa, I would like to do a slightly larger incision, axis 5.5 to 6. Because it has these plate haptics which must directly go into the capsular bag. शर्मा जी आराम से रहिए. The benefit of all these trifocals that we have today is giving the patients a lot of comfort. Even we have the indigenous trifocals which for their own price do work quite well. But of course the technology has really taken forward, and the trifocals of the day are excellent, and even for the cost it is something that is really valuable. I think we had overemphasized at one point of time the amount of loss of contrast sensitivity and the numerical values of the contrast sensitivity. Grade 1, please.
I think that's a very relevant comment, Partha. I mean, we all remember only that occasional patient who has complaints and hundreds of patients who benefit and who take it for granted the glass-free vision.
Yes, sir.
Beautiful job.
So lateral separation is what really has benefit. Grade 2, please. Quadrant, please, grade 2.
Partha, you are live. I think you forget because you are in your own OR, own OT. So you have to speak something.
Okay, sorry.
No, but wonderfully done, and you are doing it so fast.
Cornea
We can make out you want to get over with it fast.
And take you out for dinner, please. No. Happy New Year. So Namrata, you've used the AT-LISA and all the other multifocals. So apart from the literature that suggests, do you feel that there is much of a difference for the patient whenever you use these multifocals?
No, I think I was discussing with Dr. Ramamurthy also. Really don't think there's too much of a difference. I think at the bottom of it, it all boils down to what your patient wants.
Yeah.
I mean, what is the occupation, what is he doing maximally? And if you do take care of that, whether it is, with the AT-LISA or with the Synergy or with Panoptics or with any multifocal, then I think even if you have 90% satisfied the patient on that front, you are there.
I think counseling a patient is so very important when we are putting in a multifocal, and that is what makes it a lot of difference, especially if we go on to the EDOF. The EDOF demands a lot of more counseling than the trifocal. Lights on, please. So the EDOF platform is definitely also very good, and we use quite a lot of EDOFs. But first and foremost, patients do want that near vision benefit, and that really gives them a lot of comfort. So as I was saying, these microscopes make you do a lot more work than is required at times. So look at all these thin fiber strands that No. I think our own skills have been enhanced because of the excellence of the microscope and the Phaco machines. I think we are becoming less skillful than we used to be at one particular point of time.
Yes, I'm sure the newer generation who gets few years from now will only be doing, flax, and then will not know how to manually do anything.
Already told, will be 14 lakhs a day, depending on London.
11 lakhs in Delhi alone. We are preparing for that kind of number.
I think this is really a pleasure to watch for all those people who don't implant lenses in, under BSS, because this is really a treat to watch, Partha, because we all are doing under viscoelastic and we don't do it the way that you do and the way that Dr. Ramamurthy also had switched over now.
I think keeping the irrigation cannula on top gives you better control.
Yeah.
That's a good step I noticed.
Yeah, the irrigation, and sir, the irrigation cannula needs to be across the whole globe. I mean, something like this, I mean, if it is just pointing here, the stability is less, and if it is up to here, the lens slides down and the lens will not pop.
Very good. I think that's an excellent tip.
बहुत अच्छा से हो गया शर्मा जी. Thank you शर्मा जी. सीधा देखिए शर्मा जी.
So 3 cheers to Partha, Mohindeepa and their excellent team. Trenetralaya, and this is just the beginning.
Thank you, sir. Thank you so much.
Congratulations.
And this is from the whole team who were so excited to know who are the people who are going to be here for our live surgery and are going to grace the occasion.
I think we'll take some of your staff, import them to Delhi. They are so good. Partha, you are getting Sharmaji also from North India to here to operate.
Thank you very much. Thank you, everybody.
Thank you.
And thanks to the whole team who has been so supportive.
I think that was a grand finale. Thanks, Partha, for providing that lovely final touch, and we've all enjoyed your surgeries very much. And it's been a real pleasure for all of us to come to this superb institution. A great beginning has been made, and we've all enjoyed being a part of this huge, momentous occasion.
It gives us. You don't know what it means to the whole team, and we are going to take big pictures, and it's going to be all over our Facebook and everywhere. And because such a glamorous team is so difficult to find, and all of you came down, spent so much time with us, and
amazing transmission also, Partha. It was just no glitch at all. It went off superbly well.
Yeah, so I have to give a big credit to the transmission, the people, Karen transmission, who did the whole transmission system, plus our audiovisual team who have really worked very hard, and they are very much from West Bengal. So everything that is available here, and they are excellent guys. Thank you very much.
And all credit to the young coordinators, the team that did all the hard work in getting the slides ready. Yeah, Aditi, Soham, both of them
Aditi,
have put in a lot of work.
Priyam, I think they really managed
Your OT team has been marvelous. They didn't let you feel as if they're assisting you for the first time.
Shall I tell you the truth, sir? Aditi, Priyam, and Soham did the editing of the slides. Our whole optometry team, led by Prajwal Kinshuk, and the whole optometry team did the slides.
So true, sir. We are so thankful to them. They did most of the hard
Great work. All three of them, great work. So congratulations.
Thank you very much, sir. Thank you. Thanks to the whole team, and thanks to everybody for being with us. Thanks to Karen, and thanks to Rovi and his team, Moloy. The whole team had rehearsed everything, every step, so many times. They wanted it as
it showed in the clockwork precision of work, everything. Absolutely timed well, and everything taken care of beautifully. 3 cheers for all of them.
Thank you, sir.
Hooray.
Thank you very much. Thank you.
Hooray.
Thank you.
Hip,
Thank
hip,
you.
hooray.
Thank you very much, sir.
Thanks again for making us a part of this momentous occasion. Thank you.
Thank you.
Thank you so much. Thank you all.
फोटो लेंगे सर, फोटो लेना है तो
सर इधर भी फोटो है।
हाँ उधर भी फोटो
इधर नहीं ले रहे ओटी का, हम लोग बाहर है।
वहाँ भी हम लोग जाएंगे।
हाँ ठीक है, हम भी चलते हैं।
अरे